Okay, so blood lecture. We're going to cover part 1, 2, and 4. So we'll table part 3, white blood cells, for Monday. So part 1, we're going to deal with just the basics of blood and the plasma. So the functions of blood are transport. Obviously, we're going to use the blood as like our highway system through our body. So we use it to transport gases, nutrients. It regulates things, like there's elements in blood that's going to help buffer pH. There's going to be elements in blood that's actually going to help hold in fluid so we don't ooze out as much fluid. So it's regulating fluid balance. Clotting, we're going to deal with that today. So it's going to actually prevent blood loss. That's the intention of clotting. Defense, we've got our white blood cells. It's going to go out and fight any potential antigens or any harmful agents that we have in our body. Temperature regulation, most people are familiar with, faces turning red or skin turning bright red. If they're really hot, blood's coming to the surface to let off heat, as well as fingers and arms turning white because blood is going to the core if you're very, very cold. So that's a mechanism of temperature regulation. So the composition of blood is roughly 50-50 plasma, kind of liquidy components versus cellular components. So the cellular components are the formed elements. They're at the bottom of the slide here. Those are the cells, red blood cells, white blood cells, and platelets. So we're going to cover the plasma first. So it's a roughly 50 to 60%. So half to more than half is really going to be our plasma. So we'll go into the plasma specifically. So this is just a different way of representing it. So of the plasma, if we say, here's the pie chart, the majority of it's going to be all blue, which is the water. So plasma is mostly water. Then we have 1 to 3% of just other stuff, hormones that we did in Unit 1. So 7% of them will be proteins. We're going to learn the top 3 of them that are listed here: albumins, globulins, and fibrinogen. So we'll go into those more specifically. So you need to be accountable for those 3 in the order of their magnitude in the blood. This schematic I have here is if you go from a whole blood, like a test tube with just all the blood in it, you can see that 55%, so I just wrote roughly, so slightly over half is going to be plasma, whereas about slightly half or slightly under is going to be red blood cells. Of the plasma, 90% of that is going to be water, where 7% of that is going to be just the proteins. And this is just of the plasma side. And then we have here, as far as the proteins go, the 3 that we're going to be learning about in a moment: albumin, globulins, and fibrinogen. And then the rest of the plasma is just waste and other circulating components. So on the cellular side, red blood cells, that's going to be 99% of the cellular side. The 1%, and actually less than 1%, is going to be white blood cells or platelets. So next week on Monday, we're going to go through all 5 of the cells that make up the white blood cells, and then we'll talk about platelets today. So there's going to be a lot that we're going to learn about them, but you're going to need to also know. So the plasma proteins we'll go through. The 3, we've already mentioned them: albumins, globulins, and fibrinogen. Albumins, they're large protein molecules. And so these large albumin protein molecules make up 60% of the proteins that's circulating in our blood. Their job is to maintain the osmotic gradient. So what that means is when it's present inside the capillary, it helps to balance a protein concentration in the capillary to the cell protein concentration outside. So we sort of even out the concentration of proteins so that water is more likely to be retained into the capillary. If we don't have enough albumin in our blood, then you get to the capillary bed where diffusion can take place and more water is going to want to ooze out due to high osmotic, the great osmotic gradient, and really, in effect, try to dilute the proteins that are outside of the capillary. So we want to complement that by having a balance of proteins inside. So this little schematic here is if we have blood with albumin, there's a nice balance of water where it's going to want kind of balance in and out from inside the capillary bed. But without albumin, we're going to have an excessive amount of water escaping at the level of the capillary bed, too much water out. So the osmotic gradient, this first element, are these guys here. So this is with or without, maintain this water balance. But then the other action of albumin is that it's going to be a carrier protein for hormones or other things. So it's sort of like a large protein, but it acts as a docking station for something. It could be a buffer for pH, or it could be a carrier for other elements. Globulins, there are two kinds of globulins you need to be aware of. We're going to talk about the lipoproteins. That's one type of globulin, and the other are going to be the immunoglobulins. It's down at the bottom of the page. So we'll go through the lipoproteins first. The lipoproteins I have in all of these little ovals, there are different types of lipoproteins. The one that you guys are probably most familiar with are the cholesterol ones. All of these are actually variations of cholesterol, but the ones that you're most familiar with likely are the LDL and HDL. LDL cholesterol really stands for low density lipoprotein. And that's our LDL, often known as our bad cholesterol. And then the other one is going to be high density. And there's your HDL cholesterol. The low density lipoprotein is low density because it's big and full of fat. And because fat floats, it's low density. So it's going to be more buoyant. High density, because it's a, let's see here, lipo, that's fat, and protein. So it's a fat protein combination. So if it's low density, it means it's got a lot of lipo. If it's high density, it's going to sink like a rock, so it's going to have more protein going on. So that's really the difference between the HDL and LDL cholesterols. In general, LDL is considered bad because it's got more of the fat and more of the cholesterol stuff, and it's what's actually going from the liver out to the body. So it's sort of getting accused of being the cause for atherosclerotic plaque. That's why everyone's worried about getting too high of LDL. In fact, people that have, about 50% of the people that have heart attacks have normal LDL, normal cholesterol levels. 50% of the people have high ones. So clearly, just this here isn't the true answer for what your actual heart attack risk is. But for the purposes here, a lipoprotein means it's got a fat and a protein component. The protein component allows it to be dissolvable in the liquid, the watery plasma. The lipo part allows for fat-soluble substances, including even something like vitamin E, a fat-soluble vitamin, to bind to it so it can be transported. So it's really like a transporter. The LDL is low density, so it's just transporting a lot more fat than the HDL is. So on here, we can see there's other variations of the cholesterol. So of the globulin family, obviously there's this whole cholesterol story. So the cholesterols, the lipoproteins, are really globulins. So that's why they're number 2 as far as ranking of what the proteins are in our plasma. The other thing that falls into the globulin category are immunoglobulins. These guys are antibodies, and antibodies can be any of these shapes. There's a few other shapes too, but they essentially are like little Y-shaped pitchforks. You're going to get a lot more information about antibodies if you take Paul Evans's class. He'll go into excruciating detail on that. So we're just going to do the light touch as far as that goes, but we'll talk more about them next Wednesday. So for as far as all you need to know at this point is antibodies are in the immunoglobulin family, and the globulin gives you a hint that it's in the globulin family as far as the circulating protein throughout your blood. A little diversion here with regard to cholesterol. So this part, I'm telling you, is not on your test. This is more to give you perspective with regards to people freaking out about cholesterol. If you have high cholesterol, low cholesterol. First of all, I want folks to know that cholesterol is our lipoprotein. So you just need to know that. And lipoprotein is a globulin, number 2 on the protein list. That's what you really need to know. As far as having an appreciation or understanding of cholesterol is, you should know that it's important. Cholesterol is a good thing in our body. We always look at it like it's some sort of evil thing that must be eradicated. So cholesterol is used for cell membranes. If we have low cholesterol, we actually have poor cell structure. We have a difficulty with receptors and fluidity of some of our cell membranes, as well as some of our fatty acids are incorporated in there. It's part of myelin formation in the brain. We need it for bile acids. That's why we're always recycling it. Cholesterol is really easily recycled. In fact, if you're trying to lower cholesterol and our liver gets rid of it through the bile, we will easily reabsorb it. So that's why you need to have fiber in your diet. Fiber is not only just good in terms of the bacteria of your intestines, but it provides a life raft for cholesterol, the waste, to be bound and go out of your body. Otherwise, you're just going to reuptake it right again. So that's why just having fiber in your diet actually can be a factor that lowers cholesterol. So we don't want cholesterol too high for sure, but we don't want it too low. So I wanted to give you at least some good things about it, since the whole world thinks cholesterol is bad. And so it forms the backbone of all of our sex hormones. All of those steroids, those lipid-soluble hormones, are all made from cholesterol. So people that have excessively low cholesterol levels do have hormonal imbalance problems generally. And it's also involved in vitamin D conversion. So cholesterol is a very good thing. Too much is clearly bad. But what is too much and what makes it bad? Actually, high levels of just plain old cholesterol is really not bad at all. All it is a big carrier protein. What's bad is if it gets actually past the endothelium and starts to create plaque. Well, what makes it create plaque is if it gets corrupted. If it gets corrupted by excessive amounts of glucose in your blood or free radicals, that causes it to be oxidized. That turns it into like a nice little kitty to a raging tiger that's going to do damage to your endothelium. So you can have cholesterol, but whether it's good or bad is a whole nother story. Sarah. They have a greater, just being insulin resistant, not even as far as being diabetic, even just on the early insulin resistance side is a huge increase in cardiovascular risk, just by having that, because you can glycate cholesterol. So they don't ever test for cholesterol glycation, but that is one of the mechanisms it goes in. So we just know it generally gets corrupted, but glycation is one of the bad ways for it too. So this is what it looks like. People, imagine cholesterol building up under the endothelium, and it's going to cause narrowing of the arteries. So it's only doing that if this cholesterol is corrupted in the sense that it's oxidized, meaning the immune system goes, uh-oh, it was normal, good cholesterol, or normal, just normal, native LDL. So our body's good with that. But if it gets oxidized or glycated, then our immune system gets involved and says, you're kind of whacked, we need to now respond to, and it's that response that actually accelerates plaque production. Yes.
And our bodies,
There are specific nutrients that can reverse it. Statins are some pharmaceutical drugs, so it's the best is a balance of both, but you can reverse it. And so people that get a carotid IMT, they'll do an ultrasound of their carotid artery. They're actually looking, remember we have the bifurcation where you have increasing plaque deposits. They'll actually look there, and I think we showed a carotid IMT when we did vessels last week. And so you can see that, and that's a good benchmark, because first of all, you're like, uh-oh, you have plaque. Just because we see it here, you can extrapolate it to other parts of your body, and then you can undergo a pharmaceutical and a nutraceutical regimen and actually track it every 3 months, 3 to 6 months. You'll look at it and go, oh, you're not getting worse, and in fact, you're getting better, and you can actually see that. So there is regression that is possible. So generally, HDL is considered to be the good cholesterol because it's supposed to be like going from here, going, oh, let's take cholesterol away and bring it back to the liver so we could dump it into the bile and poop it out. So that's the job generally of HDL. So you want to have high HDL. Women tend to have higher HDL than men do until they hit menopause. So that's one of the protective effects, cardiovascular protective effects that women have with estrogen. But some women, they like show up, you're sort of like the overachievers out there. Sometimes like we'll get a blood profile and we're like, oh, if 50 was good, I'm like 85. I must be like A+ in my HDL cholesterol. But women that have really oddly high cholesterol, or good cholesterol, HDL, that good cholesterol also can be corrupted and can be bad. And in fact, corrupted that it can't even take, just because you have lots, it's not taking it away. So it's hard to know what's the good and what's the bad. You sort of look at these, they don't really give you the whole story. And so that's where the true risk for cholesterol is more about what kind do you have. It could be corrupted, either the liver's corrupted in that it doesn't have receptors for it to dock into. So you might have normal HDL, but if you now have messed up receptors, then so you want to think of the HDL as your garbage truck. Your body's like, hey, let's pick up the junk and let's get rid of it and dump it into the liver. Liver dumps it in the GI tract. So you either have a bunch of garbage trucks that just got full of garbage and they have nowhere to take it, and that would be the liver receptor problem, or you have defunct garbage trucks that are just not able to load. And so there's a numerous versions of how it could go bad, or that system could go bad. You basically have outgoing and coming back, but there's problems all along. So this is generally what they look like. LDL is more fat-filled, HDL is smaller, dense, more protein-filled. Made in the liver, it goes through a bunch of conversions. But what I really want to impress upon you is that the true risk is really in what your LDL. So remember I said half of the people have heart attacks have normal LDL numbers. So if you have like a normal good LDL number, you show up, the doctor's like, hey, your LDLs are fine. You don't need to have anything. Like, sweet, except for, you know, both my parents had heart attacks, you know, by the time they were 47, or, you know, I know we have a high risk, and how can I be normal? I don't want to have a heart attack, you know. And so that's where looking at what kind of LDL, are they going to be huge beach balls, or are they going to be tiny little golf balls? You don't want the golf balls. You want, for the same amount of LDL, if you have, for the same amount, you can have less particle numbers just because they're big. Or you have lots of particles, but then they're small. Little and small is the bad ones. Those are the ones that's actually going to go in and do this. The little small ones are what's going to get under the endothelium and create plaque. So you can actually, this is the formation of cholesterol. So, yeah, there. So this schematic I like to show you is you can see these are the big ones. If the proportion in your blood of cholesterol is those big ones, you're probably not very bad off. You're going to be the one that has, even if you had high LDL levels, but they were all these big beach balls, you're probably just fine. Even if you had low LDL levels, but oh my goodness, they're all these tiny little golf balls, you're going to be in trouble. And so that's where you can have a person that has normal cholesterol levels, but you really don't know, are they the good ones, are they the bad ones, even if it's LDL. So that's where there is another story. I wanted to give you that perspective. This is the graph that just says people that have coronary heart disease versus that don't. Over half of the people that have 50% of the coronary artery disease happens in people with below average total cholesterol. And this was known back in 1996. So it was in the late 80s, in the early 90s, that the cholesterol we really figured out. It's just cholesterol. Ooh, we got HDL, LDL, we got the good and the bad cholesterol. People got Nobel Prizes for this information. And so, but then they realized, ooh, you could still have a heart attack, but you still have good cholesterol. So we haven't really evolved from that. That was in 1996. They figured that out. Everyone still goes to their cardiologist, what's my cholesterol? The question should be, do I have big ones or do I have little? What's my particle number? Am I oxidized? That's the actual true risk, but those are not as well addressed risk factors. So I just like to show you this so you have a perspective of the globulins. And if we're talking about cholesterol, I wanted you to be able to leave this class knowing, having at least an awareness that there's more to it than that. Cholesterol isn't all bad. It can go bad, get oxidized or glycated and cause damage, and our immune system gets involved. But there's a whole range of subclasses that really or more of the defining factors for risk. To recap on the globulins, two groups. Lipoproteins, which is cholesterol, or your immunoglobulins. That's in the globulin family. Number 3 on the protein list is fibrinogen. We're going to talk about fibrinogen when we're done with the red blood cells, because this is what we're going to use to make clots. So fibrinogen, it's 4%, but it's number 3 of the list. We use it for blood clotting, which is known as hemostasis. Really, it's actually the last part, which is coagulation. And it also is used to wall off areas of damage. If you get a sliver in your skin and it gets stuck and it doesn't come out, and you get kind of like a pus pocket associated, that's because fibrinogen walled it off. So if you have areas where stuff gets sort of isolated so that your immune system can more effectively attack it, that's due to fibrinogen being a part of it. So it has a couple of jobs. The biggest one is going to be coagulation that we're going to learn about today. So the other remaining stuff in the plasma is like protein hormones, nutrients, waste, you know, we've got glucose zipping around. So there's other stuff that's circulating. This is going to be just in the plasma. The red blood cell side of things, if we were, or when, I should say, when we do our lab next week, you're going to get a little hematocrit tube. You're going to put your blood in here. And once you get your blood in here, we run it through a centrifuge. It lays down flat. We have a plug at one end, lays down flat with the plug outward, and it spins around. And when it spins around, the thicker, heavier elements are going to wing out to the outside. So what happens is the cells get packed up on one end and then the plasma on the other. So it separates the cells from the plasma. So this is known as your hematocrit, and we'll be doing this. So you can see the plasma side and the cell side, and you'll have a tiny little white blood cell buffy coat side here. Men generally have more red blood cells than women, so they're going to have a higher hematocrit. You can see their range is like 42 to 54, where females will top out in the mid-40s. So generally, that's it. You can get more. We'll talk about things that's going to vary the amount of red blood cells in your blood. So the formed elements, just the part that's down here, is going to be mostly red blood cells. So that's what we saw in the other chart. And then the tiny little 1% or less than 1%, that's going to be our white blood cells and platelets. The white blood cells are so few, even though there's a lot of them, and we're going to learn all their gory details on Monday. The white blood cells are so few because you want to think of them as like our police officers. They are just what's on patrol. So they're not all of them out there. They're just what happens to be circulating on their patrol route. So you're only going to see a few of them at any given. The fancy name for red blood cells is your erythrocytes. And then we'll talk about platelets when we do clotting. So your erythrocytes, or the red blood cells, carry oxygen. They are a biconcave disc. The biconcave disc means that it's like an inner tube that's been laminated. So you can't stick your arm through the hole of the inner tube. There's a membrane across the center. Can anyone tell me why there's a membrane? It's not round and like big and circular like most cells are. It's just this weird inner tube shape. What? Surface area for carrying stuff. Fit through capillaries. So you want it to be where if you're in an inner tube, it's going to fold over like a little taco more easily. It's going to scrunch through capillaries. You have a capillary bed maybe by your elbow and your arm's bent. It's got to make these kind of turns. So if you have a whole bunch of beads, they can get kind of plugged up more easily. If you've ever little inner tube shapes so they can flex and bend to go in. But the reason why they are is they don't have a nucleus. The nucleus and some organelles have been popped out of them. So what would a consequence be for that cell if it has a nucleus that's been popped out? It could be destroyed. It can't, it's just not going to survive for very long. So the nucleus, say in our skeletal muscles, we have our skeletal muscles for our whole entire life. It's multinucleated, so it's constantly doing like house maintenance, if you will. It's constantly fixing the membrane, putting new cholesterol molecules in there, fixing, receptors, fixing things. So things are always getting like a home, always has upkeep, and the nucleus is in charge of that. So if you don't have a nucleus, you just put an expiration date on this cell. The expiration date for red blood cells is going to be 120 days or 4 months. It lacks organelles because, so it's doing that in terms of giving it a limited lifespan, but the pro or the advantage of this is so that it can pack on more oxygen. It has more space now to fit more oxygen in it. So it's going to be a better carrier for oxygen. Red blood cells, any cell, any of our circulating cells for that matter, is made in the bone marrow. So our white blood cells, even our platelet fragments, and our red cells, they are all made in the bone marrow. In general, and this will cover like 98% of stuff made in our body, anything else, protein, stuff like that, is going to be made in the liver, outside of like the glands and things. So the liver is going to make all of the other elements, like the globulins we talked about, makes fibrinogen. It makes, remember angiotensinogen from last week? The liver makes that. The liver makes all kinds of random things. If it's a cell thing, like a red blood cell or a white blood cell or a platelet, that will be bone marrow. It's carrying oxygen to the tissues. It lasts for 120 days. So if it lasts for 120 days, we have to have a dedicated area for it to get removed when it's all tattered and worn out, and that would be the spleen. And I put the liver in parentheses because if you don't have a spleen, then that's what the liver will take over the job. This is a great picture because it shows you the red blood cells, it's just a nice picture of them. So you can see they're biconcave disc shape. You can see there's not really a hole in the middle, they're just kind of dented there. You can see some from the side. So this is really what our red blood cells look like up close. In order to get, or what stimulates red blood cell production from the bone marrow is low oxygen levels, or anytime you're lacking oxygen. So say we decide to drive up to, go to Colorado. And if you're in Colorado, say you're gonna go climb mountains up in Colorado, so you're going up at altitude, or you're going to the base camp of Everest, or you're going, in the mountains at higher altitude, you're gonna have less ambient available oxygen in the air. And we'll get into more of this oxygen levels when we do the respiratory system. But that lower availability of oxygen tells your cells, oh my goodness, if we're not getting enough oxygen, we need now more carriers so that whatever we're getting in, we can load up more buses to carry it out to our body. So low oxygen is going to stimulate a higher red blood cell production. So they last for 4 months. So we always have a constant production going on anyways. It'll just increase that production if you're going to be in a lower oxygen environment. So here, this is my little schematic for the low oxygen. So altitude's where you're going to get more low oxygen. It's made in the marrow. Again, this is a constant production of red blood cells coming from the marrow. And then in it is hemoglobin. Hemoglobin has these little heme spots where iron is located. Iron binds quite effectively to oxygen. So when iron's bound to oxygen, that's what the purpose of the hemoglobin is. So it's helping to, I always think of these here as red blood cells like a hemoglobin, or I think of red blood cells as an oxygen bus. So you've got a big old bus, you've got all this hemoglobin with iron, little irons like the little seats that the oxygen would sit in and actually bind to. And so you're loading up these little buses with all kinds of oxygen molecules. You're just trying to pack as much in as possible. When they get worn out, again, it's broken down by the spleen, and we take the iron and we reuse it, send it right back to our bone marrow so that we can use it again to make the next batch of red blood cells. And then we have bilirubin, which is just a waste product that's going to get excreted. So here we have the spleen. This is the spleen that takes out red blood cells. But once it takes out the broken down red blood cells, it takes the iron and it's going to move the iron and bilirubin out. So from the spleen, we go through this hepatic portal system. We've learned about the hepatic portal system last week. Anything that we absorb from our GI tract, we didn't want to just dump straight into our inferior vena cava and just next stop heart. We wanted the liver to inspect it. Same thing for the spleen. The spleen sends its venous supply also to the hepatic portal system so that this waste, this bilirubin that's going to be coming out of the spleen, will go to the liver, and then the liver then can put it into the gallbladder and then send it down into our intestine, and then they'll go out. So the bilirubin that's going out is the waste component that goes to the liver. The liver's garbage is the gallbladder and bile. And bile goes into your intestines and it goes out with the feces. In fact, it is the bilirubin, this pigment molecule, that gives feces the brown color. So here's the destruction process. You have a red blood cell. Here's the spleen. Break it down. The hemoglobin. We have waste products. The globin is going to go out. It's just a fatty protein breakdown. The heme breaks down into the iron part, which goes back to the bone marrow. The bilirubin component is going to get to the liver and then out, in an ideal world, out the gallbladder, out as bile, and out through the GI tract. If we don't get rid of it efficiently, or maybe we're making so much that our liver can't keep up, but we have a buildup of bilirubin in our body, what condition would that lead to? Jaundice, exactly. So that yellow pigment, that's bilirubin, and that's what people will get on their skin if they get jaundice. So it could be due to somebody having a failing liver, so it's not processing, or what if maybe they're having an excessive red blood cell destruction. Now all of a sudden they have it. So it could be from a number of reasons. The bilirubin is the pigment molecule. The liver's job is to take this large bilirubin molecule and it sort of chops it up into tiny little particles that can easily be dumped into the gallbladder as bile. So it kind of takes a while for it to do the chopping. So if somebody has jaundice, their best bet is to go get UV light on their skin, because the powerful UV rays actually break up bilirubin. So then now you have the little broken down pieces circulating, and when it makes it back to the liver's like, good, I don't have to do anything to it. I'm going to put it straight into the bile. So you can help out somebody with jaundice by just exposing them to UV light. Most people have heard of this when it comes to postnatal newborn babies. So as a fetus, babies, while they were in utero, had hemoglobin, red blood cells, that were actually more powerful hemoglobin. They bind, the heme component has a stronger binding affinity for oxygen. That's because when the baby's placenta interfaces, or side of the placenta interfaces with mom's side, the blood doesn't mix with mom. The baby's not getting mom's oxygenated blood. What happens is mom's oxygenated blood comes right next to baby's oxygenated blood, and through diffusion, oxygen gets off of mom into the baby. And so that's just basic concentration gradient. Mom's got more, baby has less, so it's just going to go that direction. But in order to extract even more away from mom, the baby's hemoglobin is stronger. It's like a stronger oxygen magnet. So even more oxygen's removed from mom to get back to the baby. But once the baby's born, it doesn't need this really high, powerful, hanging on to oxygen, high affinity hemoglobin. So once that baby's born, they just start destroying all of this fetal hemoglobin, and then their bone marrow is remaking new normal hemoglobin, like red blood cells with normal hemoglobin, right away. So when babies are first born, there's this huge load placed on the liver because of the dumping of the fetal hemoglobin. So that it just takes a while for it to clear, but that's why babies often get jaundice, because it's not like they have anything wrong with them, but they're naturally destroying their own hemoglobin from the fetal stage to replace it with postnatal hemoglobin that's got a normal affinity. Because they want that hemoglobin, when it gets out to the tissues, the growing tissues, to unload oxygen more easily, not hang on to it as tightly. So there's that element of bilirubin. So I want you to know bilirubin's broken down. It's going to have jaundice if like an adult has some compromised liver, fatty liver disease, chronic alcoholism, hepatitis, or increased red blood cell destruction, they're going to get jaundice. The other element that I wanted to let you know is you can actually see the breakdown of bilirubin before your very eyes, and that's what a bruise is. So someone gets like socked in the face or gets whacked in the head, you know, like walked into a door or something like that. You get like a giant shiner. So at first it's going to be purple, because what happened is the damage broke capillaries, blood went out into the tissue. So now you have red blood cells that's kind of out in the tissue. That's what a bruise is. But then over time, that bruise is going to fade, and it kind of turns all bluish, and then it turns like greenish, and then it's like a yellow color. All of that color changes of a bruise is this bilirubin literally breaking down before your very eyes. And so it'll clear better, obviously, if you're going to have it exposed out to the UV light, but that's what it is doing. So you're naturally seeing that happen. It's just stuck out in the tissue, so it's not circulating. So ultimately, all the breakdown components will just finally, when they get small enough, will drain out through the lymphatic system and then ultimately make it to the liver and out. But that's the pigment component that I'm going to tell you about, or I told you about. The other thing is the pigment is broken up by UV light, and no different than, say, sun coming in your living room. You know, if you have a patch on your carpet that's all of a sudden fading because the sunlight's on it, that's the UV light actually breaking apart the pigment molecule. So we have here anemia. What is anemia? And then we're going to do the opposite, which is polycythemia. Anemia really just means low oxygen delivery. So I'm going to circle these second two: aplastic anemia and hemolytic anemia. Aplastic anemia means you just didn't make enough red blood cells. So these two have to do with the amount of red blood cells available. So if you think of your red blood cell as an oxygen delivering bus, aplastic anemia means you're not making enough buses. So your body is just not getting enough oxygen because you don't have as many delivery mechanisms. Hemolytic anemia is anytime you see lytic, that sort of suffix there, lytic, means something's breaking down. So hemolytic anemias means something is destroying the red blood cells. Your bone marrow is just fine. It's making red blood cells just fine, but something else is making them non-functional or destroying them. Things could be like sickle cell anemia, where they just turn into a weird shape. They get plugged up. They're going to be not very good at delivering, not going to have, or malaria cause damage. So those are the two types in terms of number of red blood cells. Then we have this other one, pernicious anemia. Pernicious, does anybody know what the word pernicious means? Sneaky. So what's sneaky anemia? It's sneaky because if you did a blood cell test on them, like a hematocrit, they just have normal red blood cells. Like if you have aplastic anemia, you'd have what's this slide here. You'd have, oh, sorry, that's malaria. You have this is normal red blood cell number, and then less. So this would be like an aplastic. You just didn't make enough. Pernicious is, looks normal. You have enough red blood cells there, so you have enough buses out there. But, and that's the sneaky part, because it looks normal, but the buses don't have enough seats. You don't have enough hemoglobin and iron, so there's no binding sites. So it's kind of deceptive. You have all the red blood cells there, but they don't have the carrying capacity. That's because the vitamin B12 plays a role in forming the hemoglobin. So you reduce your carrying capacity. We will talk about this again in Unit 3 when we talk about the GI tract, because it has to do with a specific element, intrinsic factor that's in the stomach. So we'll be visiting this. So really anemia is just you have low oxygen delivery. Either you don't have enough red blood cells, aplastic, or the ones you have, you're destroying or get messed up, that's hemolytic. Or you have a normal amount of blood cells, you just don't have enough B12, so therefore you don't have enough seats for the oxygen to bind to. On the opposite side, there's polycythemia. Polycythemia means more than average red blood cells. How would we get more than average number of red blood cells? We already talked about high altitude where there's low oxygen in the air is a signal to our body to go, hey, we don't have very much oxygen outside that we're breathing, so let's make more red blood cells so that whatever oxygen comes in, we have more places to bind. We're actually going to capture more of them so we can deliver it more effectively to our cells. So blood doping and erythropoietin are two other mechanisms that are, well, erythropoietin is a natural mechanism in the kidneys. It's actually what tells our bone marrow to increase red blood cell production. That's the hormone. But erythropoietin in the context that I have here is a drug that you can take that will tell the bone marrow to increase production. It's a banned substance in sports. Blood doping is also something that's been done. Athletes will do on the day of an event. It starts a couple months earlier, pull a bunch of blood out, skim it off, skim your plasma off, centrifuge it, pull the plasma off, refreeze or freeze your red blood cells, save it for later. Meanwhile, after a couple months, your blood's, you get replenish your blood, so you're back to normal blood levels. But on the day of your event or just the night before, you inject yourself with your thawed out red blood cells, and now voila, extra oxygen deliverers. And so now you can have that edge if you're at the World Games, the Olympics, that's actually going to edge out over somebody. So blood doping is something that gets tested for. So we'll go through the blood types. The basic blood types that we have, there's 4 basic blood types. I mean, you can go further into this, but we're just going to do the basic ones. The 4 basic ones, you really have, it's really about your cell and what kind of marker is on the surface of the cell. So your cell surface marker, you have choices, A or B, and then a combination of. So like one cell could go on and put a little name tag on its surface and say, hi, my name is A. And you put a little A marker on the surface. Another cell picks up a marker and says, hi, my name is B. And they have a B marker on the surface. Or you can have a cell that's like, I'm going to get both markers. I'm A and B. So that's type AB. Or then you can have the other one that's like, you know what? I don't want a name tag. I'm going to be like Paul Evans. I'm just going to be like, ignore me. So then you'll have no name tags. And then you'll be type O. That'd be like type nothing. And so that is the variation. So you really, and the antibodies, not these little color-coded guys here, which happens to be part of our globulin family, but just to relink that and bring that back up. But you'll have the antibodies, and what antibody you have will attack the name tag that you don't. So if you have the A name tag, hi, my name is A, then your plasma will have anti-B antibody. If you're a B surface marker, then your plasma will have an antibody that will attack any A. So it doesn't matter if it's the AB, there might be one like that is like you if you're B, but as long as this attacks that, this guy won't be able to go over there. So the critical element about naming blood types is what's on the surface of the red blood cell. What marker do you have on the surface of the red blood cell? Donation from one person to another has to do with the donor's red blood cell, what marker they have on their surface, and the recipient's plasma antibodies. So if they have the plasma antibody anti-B, then who cannot donate to them? B or AB, because it has anything with a B on it. So it depends on the recipient's plasma, but the donor's cells. That's going to be the most important. You, just for the sake of just not adding extra elements, don't think of the donor's plasma. That's just irrelevant to this, to where we are right now. So here we are, surface marker A, person's type A. Surface markers B, they're going to be type B. So both markers, A, B, and type O. So then in the plasma, what type of antibody is the A people going to have? Anti-B. So I have them shaped on here like a little curve because I figure the top of the B is a curve. And the type B people are going to have anti-A. And I have them shaped more like angular because I figured that fits on top of an A better. These guys are the anti-A's, so they can't attack themselves. They'll only be able to attack any incoming A. O has both anti-A and anti-B. So as I indicated, AB wouldn't have antibodies because it would attack itself. But because O has no surface markers, it has both antibodies in it. If we have AB, it has no antibodies. AB, otherwise it would attack itself. So it has no antibodies to attack any incoming blood. So as far as AB goes, if A were to donate here, it can do it because there's no anti-A. B could also donate to there because there's no anti-B to attack it, right? And then O has nothing on the surface, so it can go in there. So AB is the universal recipient. It's not going to reject anybody because it has no antibodies to fight off. So anybody can donate to AB. But then type O, because it has no surface markers, it can easily go to B because the anti-B antibodies are looking for a B and there's none on it. So it goes in, same if it's going to A. The anti-A's, sorry, pen. Okay, weird pen. If it goes to A, it's looking for anti-B. And so there's no B on it. Or O is like stealth blood. It can go in, it's got no marker, so no matter what the antibodies are in the plasma, there's nothing for it to bind to. So that's why it is the universal donor. So we have AB as the universal recipient because nothing, it's not going to fend itself. It's not going to fend off any incoming. O is going to be the universal donor because it can go out, but nothing will bind to its surface. You have a cell with a name tag on it. So you either got the one with the A, you got the one with the B, you got both of them, or you got neither of them. So that's kind of your cell. And then the antibodies you have in your blood already to defend yourself from any incoming wrong blood, if you want to think of it that way. The RH element is something different, but similar. So if we have a red blood cell here, and it's got the A surface marker, and we have a cell over here, and say this one's got the B. We've got this one over here. We'll say this one's AB. And we have O. And we have the antibodies in the plasma. So what the RH factor is another surface marker. So if this guy has an RH surface marker, then you would say this person is positive. They are A positive because they're positive that that's there. The positive or plus means that it's present. It's in fact there. If this one has an RH on the surface, this would be O and it would also be positive because there's a RH factor. But if there's none here, what would this guy's blood type be? Yeah, so they're negative for the RH. They'd still be called AB, but negative in that that RH is absent. And then this one would be what? B negative, exactly. That is RH, so it's not going to be called ARH. So it's not always named exactly just what's on the surface. It just says it's there or it's not. That's really the plus minus. Now, as far as the antibodies go, if you have the RH, of course you're not going to have the antibodies because you're not going to attack yourself for RH. But if you're negative for RH, you're not born with opposite antibodies. You're not born with antibodies to attack RH. That actually comes if you ever get exposed to it. So for RH factor, and complication would be if the person, so this is the patient, this patient is RH negative. So I put a little minus sign. No RH factor. Blood is here. It's O negative, right? So there's no RH factor. There's no surface markers. Somebody, an O positive person, donates to them. All right, goes into this person, O to O. That's not such a big deal, except for now, the person's never seen RH before. Their body just now gets exposed to these RH surface markers on this new incoming blood. It's going to take a few months, but they develop antibodies that are actually going to be, would be attacking it. But meanwhile, blood's turned over by then, so it really didn't cause any damage, except for now, you've created a set of memory cells in this person for RH positive. So you get away with it the first time, but then this person needs blood again, and they're like, hey, I did fine with O positive blood last time, even though I'm O negative, just go ahead and give it to me again. Then that would be a big problem, because then the second time it goes in, the antibodies are already established and they're already there waiting, and they will go and clump and cause the glutamate. So you have a shot at like a free pass on the first one that you built up the antibodies. It's just the second one that's going to suffer the consequences. So this is an important concept when we consider hemolytic disease of the newborn. This happens only if it's an RH negative mother. RH negative moms, get a little picture. So if this mom here is RH negative and her baby is RH positive. So the little RH factor is sort of depicted like red dots, like not like measles or something, but you have RH factors. So the mom, her body senses it. Blood's not supposed to mix, but there is that happens. So that happens. So all of a sudden the mom built up some antibodies. Baby's out. She could have had like 8 babies. This could be just baby number 1 that was RH positive. And 2, 3, 4, 5, 6, 7, could all be RH negative. Nothing happened. Everything's fine. It's just the next RH positive baby, number 2 for RH positive baby, not total baby, would then be the one that would suffer because the mom's antibodies would immediately come and attack the baby once it's exposed to the blood and it's aware of. So there's a concern for only RH negative moms that have RH positive kids. So what happened is this stuff called RhoGAM is given to pretty much any RH negative mom just to prevent these from being made. So in fact, you get the RhoGAM shot, that those antibodies that you get made to attack the next baby, they don't get made. You block that antibody production and you block the formation of those memory cells. As a recap, we did plasma, 2 proportions. We did the proteins in the blood, red blood cells, where it's made, how it's destroyed, what it does, what we recycle, what bilirubin is. We did blood typing, the marker, surface markers, and the plasma antibodies, and then the RH components, the RH hemolytic disease of the newborn with the RH negative mom, or even just a person that's RH negative getting RH positive blood. It's really the same kind of thing. It's just more of a concern with moms as far as a standard of care. Platelets, hemostasis, blood stopping. That's what hemostasis is. For hemostasis, there's 3 main parts. The confusing part is the last part. I'm going to wade through all of this with you so that you have a sense of the big picture for this. Blood clotting is really confusing. And I want you to have a sense of the magnitude of elements that are involved in blood clotting. But then I want to still have you understand the big picture. So when we kind of wade through giving you kind of an idea of the big concepts and where some of the detail could be, then we're going to kind of come back to this and then go to just what you really need to know and try to put it in perspective for that. So that's kind of my plan here. So what hemostasis is prevention of blood loss. Like if you have a vessel that's been cut, how do we stop, the hemorrhaging? So the first step is going to be vascular phase, is where you're just going to constrict the blood vessel going to it. Let's minimize flow to this broken pipe, if you want to think of that. So that's pretty obvious. Then the second is platelets that are circulating around. They're going to like plug up the hole if possible and try to form this temporary plug. There's a platelet plug, which is different than a clot. It's like this sort of temporary thing. And then there are elements, a whole bunch of chemical reactions going on that's involved in coagulation. What coagulation ends up in is a complete clot. So a clot is different than a plug. So you have a platelet plug, and then ultimately what a clot is remember fibrinogen. That was number 3 as far as our protein circulating in the plasma. And so it's by itself not doing any harm. It's not doing anything, but when fibrinogen converts into fibrin, those are the strings. That's what's actually going to create the clot. And what the clot is like a beaver dam. You get these stringy things that's going to trap red blood cells, and it's going to create, and the strings are also going to hold the damaged sides of the vessels together. It's going to initiate repair. So you have this conversion is ultimately what a clot will be. So fibrin are the basic components, the main components of a clot. So just know that's where we're going with this. So the coagulation phase ends in that conversion of fibrinogen into fibrin. So this is a little picture showing injury. We have a cut of the blood vessel. The vascular phase is now we are reducing the size of that blood vessel. We're able to minimize flow into this area to minimize loss. Then the platelet plug part is we're getting a little platelet plug to now temporarily obstruct this while we get the chemical process going on to ultimately make a full-blown clot. So the second one here is the full-blown clot where you see all the fibrin and red blood cells trapped, where this up here one is just like a real temporary light plug from the platelets. So that's kind of like a big general view. So we have the vascular phase, reduced flow. Platelet phase, temporary plug, coagulation, conversion of fibrin. Let's make the full-on clot. What are platelets? Before we get into this a little bit further, they end up being particles of cells. So in the bone marrow, we get these big wobbly cells like this with these little weird extensions. They pinch off, and so platelets are pinched off fragments from these cells. So they're just cell particles. And in fact, when we look at are going to look at blood slides next week, they look like dust on the slide because they're like little dots that are sporadic throughout the blood. So what they do is they are smooth like these guys when they're normal. But if they've been activated by something, they get all spiny and sticky. When they're spiny and sticky, you can see how then they would be sticking to more. It's like a dog pile is going to occur. So what would activate them? Something that's in a vessel break. So an example would be if we are all like blood cells or platelet fragments, and this is our room is a blood vessel. And something comes through the ceiling, damage the blood vessel, where blood would like hemorrhage out through the ceiling. What is something that would be in the ceiling that we as blood components be exposed to that would be an abnormal thing, but normal for the wall, vessel wall in this case? Something like, say, the insulation, right? We wouldn't normally be exposed to insulation. Blood in a blood vessel wouldn't normally be exposed to direct collagen or elastin or some of the components of the wall. So if your cut is going through a vessel, some of these wall components go in, just like insulation coming in, it's a sign of damage. So one of these little smooth platelets bump up to it and turn into this little puffy little sticky thing. And then other platelets hit it. And so you end up with this massive dog pile, and that's our temporary platelet plug. So that's sort of the general view there. So it activates these clotting factors. So the platelets dogpiling together in their temporary plug is going to then lead to this whole coagulation phase. And I want you to see, so this is where I want you to get a taste for and view of the complicated nature that is clotting. You see, like, you know, one step leads to the next step and the next. There's all these different steps. They're all clotting factors. In fact, here's a partial list of all these clotting factors involved. So there's a multitude of steps going through. And not only do you see these here with these Roman numerals, but look back here, we can see some of these Roman numerals, although tiny, have subscripts. So not only do you have number 7, but you can have 7 subscript A, which means there's subscript B. And there's like, so there, I mean, there's loads of these things. So it's very, so you can see where hemophilia, you can have a problem with any expression of any of these. So there's a lot of things that can go wrong. So I want you to have an appreciation of the complex nature, but we're still gonna thin this out and actually hopefully make it a little more manageable. So if you're looking up in the book or reading about it, you'll notice there's an extrinsic pathway, trauma to extravascular cells, intrinsic pathway, it has to do with damage to intervessel walls. There's different pathways. They ultimately come to this X. I sort of put factor X. So basically, whichever pathway you read about in your book, you kind of come to the same endpoint. You come to this factor X. This factor X then is ultimately what's going to convert prothrombin into thrombin. Prothrombin is something else that's just circulating normally in our blood. Here's fibrinogen. Fibrinogen, we already know, is circulating normally in our blood. So this thrombin takes fibrinogen to become fibrin, and that is our clot. So we're going to put this, kind of weed this down a little bit. So here's our list of just some of the clotting factors. You don't have to know them. I just wanted you to see them in list form. Here is sort of the common pathway, the second portion. You get to the factor X, whichever intrinsic or extrinsic pathway you're at, you get to this factor X, you get to this common pathway where you take prothrombin, which is normally in the blood, to convert to thrombin. Thrombin then takes our fibrinogen, which is normally in the blood, and turns it into fibrin to become the clot. This is the clot. Those are fibrin strands. That's the red blood cell inside of it. So this is what a clot really is. And this is going to hold the sides of the damaged walls together, trap all these elements to prevent blood loss. So the summary here is you want to minimize blood flow to the area of damage. You do a temporary platelet plug. It actually is going to release a chemical that then does the whole coagulation thing. The coagulation ends in fibrin formation. So this slide, put a star on. This is the one that you really need to know. So this is what we're going to distill out for our test. We have, when you have a vessel, here's our blood vessel, and we have platelets. They're these little black dots circulating. This is the blood. Also in the blood, we have prothrombin already there. We also have fibrinogen. And these little dots here, platelets. So these things are already in the blood. They're just there, circulating around. So then something happens, we have some sort of knife cut or some damage to the vessel wall. So now we have exposed vessel wall. What happens first are the platelets are going to do a temporary plug. The platelets do a little temporary plug. So that's them there. And what they do, once they make this temporary plug, is they release a chemical known as prothrombinase, also known as factor X, some variation of factor X. So actually that's kind of where this comes in. Prothrombinase is going to go to the prothrombin that's already in the blood and cause it to become thrombin. Plus, it also uses calcium to do that. So calcium and prothrombinase together come in here to this prothrombin. Prothrombin, I'm going to draw it like here, like an enzyme, plus calcium. Now that we have thrombin, thrombin then comes down and it goes to fibrinogen and turns fibrinogen into fibrin. And when we get fibrin, that is now the big clot stuff where we have a true clot. So fibrin is, when you get to the fibrin stage, you have a full-on clot. The platelets were just a temporary plug that released a chemical that got the two elements that are already in our blood to do the double-step conversions. So that's what coagulation is.
Which step is the plug?
Yeah, so the platelet aggregation is just the temporary, we'll say temp plug. And this one equals the actual clot. The fibrin is the clot itself. And so the clot is hard to break up. But I want, before we talk about breaking up a clot, because clots have a job. You want to have a clot, we want to repair, and then we want to put the clot away, send the clot away. So we have elements that actually is like scissors that have to go in and actually chop up the fibrin strands to destroy it. But before we talk about breaking down a clot, let's go through some of the elements to prevent clot formation. And that is known as anticoagulation. Seems obvious, but it's not always. Anticoagulation is what can you do to prevent the clot from forming in the first place? So it's not breaking down a clot. So I'm going to have you learn 3 anticoagulants. They're all ones that you may have already heard of. Aspirin prevents the platelets from being sticky. It stops the platelet plug from forming or reduces the likelihood of it forming. This is important in people that we talked about blood vessels. If you have a blood vessel and say you have plaque development here, so when you have plaque development in the wall, remember we had flow coming through there, and if the flow as it comes around a plaque, we can see that there was that turbulence on the other side. Where you have turbulence, you're going to have slower flow, and so the little platelets in this area, in these areas of turbulence, are more likely to actually bump up against each other and stick and activate each other. So that's how people that have plaque, yes, we're worried about the plaque narrowing and blocking off our coronary arteries, but just the fact that you have plaque actually increases your risk for stroke immensely, because now you have all these little eddies swirling around, all these little plaque junctions that now make it more likely for you to make a clot, which could then form, go through this whole process of the platelet plug, and then now you have a clot. Now it's going to be mobile, and it can go on and obstruct, create a stroke or some sort of embolism somewhere. So that's one of the risks there. So the second one is going to be heparin. Most people are familiar with heparin. Heparin just prevents the formation of thrombin. If you don't make thrombin, you don't have to worry about fibrinogen getting converted. So you're not going to get the full-on clot. So heparin blocks thrombin formation. The third one is Coumadin, also known as warfarin. So the same thing. It is a drug given to people to actually prevent vitamin K absorption in the large intestine. Why do we need vitamin K? Vitamin K is a really good thing. It's really good for bones. It's good for a lot of things. It also helps our liver make prothrombin. So if somebody is on long-term anticoagulants, this is the one that's often assigned to people, or had been. They have newer ones now, but it's the one traditionally had been assigned, in that it's going to prevent your liver from even making prothrombin in the first place. So you have less prothrombin available, therefore you're less likely to convert to thrombin. So this is more of a long-term type thing. So ultimately, these anticoagulants prevent fibrin from forming. So you're just not going to get the clot or reduce likelihood. So fibrinolysis, the term lysis means breaking down. So this is after the clot's formed. If the clot's there, how do we get rid of it? Well, the answer is plasmin. Plasmin is our body's main clot buster. If you are having a stroke, one of the things that's mostly injected as far as the drug goes is streptokinase. So that will be a clot buster. So if I were to ask a question about which of the following agents is, you know, a fibrolytic agent or involved in breaking down a clot, would it be heparin or would it be plasmin? Plasmin. What does heparin do? Does it break down a clot? No. Stops the formation, yes. Sometimes people just think it's the same thing, but I just want to make sure you're on two different sides of the production line, either stopping the creation of the clot or, oh, we already have a clot, now we have to deal with breaking it down. So obviously plasmin is something we normally have. We want to clot, we want to build a repair wall, and we want to then break it down. That's a normal process. If you have a pathology where you had a clot obstruct, like in a stroke or the coronary arteries, then you're gonna have to inject somebody with streptokinase to go in and be like a little chainsaw to break up the clot to resume blood flow. So those are, and there's other agents there. That's just a really common one. So if you know plasma, red blood cell story, you know blood typing, who can donate to who, that kind of stuff. And as far as blood clotting, you bring it right down to this one. So the clotting, the most important page is this one, that you know these 3 steps. Then from this page, then you know the anticoagulants, where they work. You know, like a question could be, you know, what does aspirin do? Prevent platelets from aggregating. What, which would prevent thrombin formation? That would be heparin. You know, so that you know the target for each one of those 3 anticoagulants. And then what is the one that's a fibrinolytic, breaking down completely? That would be the plasmin and streptokinase.